Hi, I'm Mary Beth Gilliam, and this is the Outperform Cancer podcast, where we discuss actionable anti-cancer strategies found in peer-reviewed scientific research. If you've been enjoying this podcast and would like to support it, the best way to do that is to take a moment to follow the podcast, click like, add a comment, and best of all, share it with a friend. You can also visit outperformcancer.com and sign up for our newsletter. Today, Dr. Henry Park joins us to talk about radiation oncology. And trust me, the information he shares is eye-opening. He'll introduce us to the cutting-edge RefleXion Scintix radiotherapy technology now available at Yale Smilow Cancer Center and discuss surprising advancements that could change how we think about treating cancer. Dr. Park is a leading expert in the field. He's the Vice Chair for Clinical Research, Chief of Thoracic Radiotherapy at Yale School of Medicine, and Assistant Medical Director of Clinical Trials at Yale Cancer Center. His full bio is in the show notes, and it is seriously impressive. So, why is this conversation so important? Well, that's because more than half of all cancer patients, about 50 to 60%, will undergo radiation therapy. It's also a technology that is rapidly advancing. I became interested in radiotherapy when I was first diagnosed with metastatic cancer. My initial scan suggested I might only have a few cancerous spots in my spine, what's called oligometastatic disease. Oligo means a few, so a few cancerous spots. At the time, I found research from Canada showing that some oligometastatic patients could be treated with curative intent using stereotactic ablative radiotherapy, sometimes called SABR, S-A-B-R. And isn't that what every metastatic patient wants to hear? That you could be treated with curative intent? It's certainly what I wanted to hear. So that led me to lean in further to the research, and it led me to a company called RefleXion. Their technology sounded super interesting, was state-of-the-art, coming out of Silicon Valley. But what really caught my attention was the vision statement for the company, which said, to reveal cancer as never before and beat it for everyone, everywhere. That vision stuck with me. I said, I got to follow these people. So ultimately, unfortunately for me, further scans revealed that I had more extensive disease, which meant I wasn't oligometastatic, which meant I wasn't a candidate for this approach. But I never forgot about RefleXion, and I continued to follow the company over the past 5 years. A few months ago, I read about the groundbreaking work Dr. Park and the innovative team at Yale were doing with RefleXion, and I knew I wasn't the only patient who'd want to know more. I was thrilled when Dr. Park agreed to speak with me, but I knew Dr. Park was my kind of doctor when he said, I like to think big. So, if you like to think big, you are definitely going to want to hear this powerful conversation on radiation therapy, which covers using radiotherapy with curative intent, even for some stage 4 patients. Why your first shot at treating cancer is often your best shot. How the timing of radiation, chemotherapy, and immunotherapy impacts outcomes. How much radiation is too much? Which sex, male or female, tends to benefit the most from radiation treatment? And who might be an ideal candidate for the new RefleXion radiotherapy treatment? This episode is packed with insights that could change the way you think about cancer treatment, and maybe, for some of you, it'll open up some new possibilities for care. So join me in welcoming Dr. Henry Park. Hello, Dr. Park. Welcome to the Outperform Cancer podcast.
Thank you very much. It's really a pleasure to be here. And thank you for inviting me.
Well, we're really excited to hear what you have to say, especially about the history you're making with the new technology that you have at Yale Smilow. Let us know, what is so interesting about this new machine?
Well, thank you for asking. We have a new machine called the RefleXion X1. What it can do is standard radiation therapy I'll be using some acronyms today, which I'll explain. There's one thing called IMRT, or intensity modulated radiation therapy, which is where we can use radiation therapy in a very conformal way and design a radiation plan that can go to almost any shape in the body in terms of the high dose and where that goes. Now, we have something called SBRT as well that it can do, which is something that other machines can do as well for both IMRT and SBRT. What SBRT stands for is stereotactic body radiation therapy, also known as SABR, or stereotactic ablative radiation therapy. So there really is a whole set of acronyms that we'll be using. But I want to start with that part, because to understand that SBRT is really the basis of what this reflection machine is based on. So the first part of it is that SBRT is used with high doses of radiation in just 5 sessions or fewer to a very small area for the most part. So if we're treating something that's much longer, if we are treating multiple areas of the lung, let's say, or other parts of the body, we'll probably use something more like IMRT and use it with a low dose for over the course of many weeks. We do it once a day for several weeks. Now with SBRT, we do it only in 5 sessions, but give a higher dose each time. And we can get away with it because of the imaging quality we have, as well as the size of the spots that we're treating, that we can really avoid the normal organs nearby and treat the safe doses, even if we're giving the tumor a very high dose. I just want to also mention the reflection machine itself and what it can do beyond that. So there's something called biology-guided radiation therapy, or Scintix. And what that does is actually uses the PET scan signal that the tumor actually emits a signal that you can detect on a PET scanner. The machine has a built-in PET scanner where as a tumor moves, and the tumor can move in a couple of ways. One is with breathing motion, just normal breathing that you do. It can move that way, or it can move because you moved a little bit, because you shifted on the table a little bit. For whatever reason that the tumor moves, the radiation is actually able to follow along with the tumor automatically.
Wow.
So it's not where you have to tell the machine, where the tumor is going in real time. It'll just know based on where the tumor is moving. So that's the new advance that we have here. We were the 5th institution in the world to install this technology. So we were the first to do that. But what we did do first was to do a radiation plan with this Scintix technology to one spot, and also use SBRT to another spot, and plan them at the same time, so that we can account for any dose. We can account for any dose spillage from one to the other, and be able to calculate it all at the same time. So it's more of a technical issue that we were able to figure out and to be able to use on a patient. But the main reason that it's exciting is because the whole goal is to be able to treat multiple spots at some point with Scintix. And we're not there yet. But one day, if we can get there, then we hope that we can treat multiple metastases at the same time from any sort of cancer, and be able to target them all at once. And if we could do that, we could potentially expand the role of radiation therapy, even in patients with multiple metastases, and be able to treat them efficiently, and be able to use radiation better to be able to synergize and work better with the systemic therapies that are improving all the time.
Wow. Okay, so I want to break that up for some of the listeners out there, because there's a lot of really important information that you just shared. So what I heard was there's 2 general kinds of technology that we're talking about today, IMRT and SBRT. And the SBRT, that technology is unique. So it could be ablative. And I'd like you to just explain, why is ablative therapy important to cancer patients versus the IMRT, which is not ablative? Can you explain why that's important?
Absolutely. So radiation therapy can be used for all sorts of reasons and at all sorts of doses. So one important thing to know about radiation therapy is that the dose itself is in and of itself not that important. It's really the number of gray is the units we use for dose of radiation. But you have to also think about the number of fractions, meaning the number of times it's delivered. So if we say 30 gray, and you say, I received 30 gray, it doesn't really mean anything to me unless you say it was 30 gray in 1 fraction, 30 gray in 5 fractions, 30 gray in 10 fractions, or even 30 gray in 30 fractions. So what that means is that a 30 gray in 1 fraction can really be very ablative in terms of being able to really destroy the tumor fully with that kind of dose. Now, we have to also make sure we don't destroy other organs in the body as well, and that they can recover as well. So we have to be very selective of when we can do all 30 gray at once. What we have done conventionally in radiation is give only 2 gray per day, approximately. So if we were to do 30 gray, we might do it in 15 or maybe 10 fractions to be gentler and let normal tissues recover more than the tumor itself. So if you imagine each fraction, you are able to treat the tumor to some degree. Each 2 or 3 gray fraction is not going to kill everything. But at the same time, it'll if you do it once a day, it'll let normal tissues recover, and you keep giving it over and over again. And eventually the tumor will respond, or that's the idea, is that it can respond and hopefully shrink. And any symptoms you have from the tumor may hopefully be relieved as well. So we often use the lower doses that are more fractionated, meaning that you extend it over a longer period of time. We do that for cases where we want to be gentle about things. We want to fix a certain problem, a certain symptom that you're having, or at least alleviate it, but without causing a lot more side effects either. So if let's say you have a bone metastasis that's causing you pain, or you have a lung metastasis that's bleeding and causing you to cough up blood, that may be something where we use a low dose because we don't want to interfere with the chemotherapy or immune therapy or targeted therapy that you're receiving as well. We give it a low dose each day just for a few days, and we try to let that to help relieve the symptom while you get the systemic therapy that will work on your whole body. Now, let's say you only have disease that's in one area that's all the disease you've ever had. So let's say in stage 1 lung cancer, you might only have one lung nodule that we're treating. Or if you have stage 4 disease and you have metastases, but that maybe only one is growing, and you want to be able to maintain the systemic therapy that's working everywhere else, but you only want to target one area and give it a really whopping dose to try to essentially wipe it out and make that issue, to really take care of that one issue. Then when you have a very limited field like that, you can go to a much higher dose, or at least a much stronger dose. It might look like the same 30 gray, but maybe we do that in only 5 fractions, or maybe even 3 or 1 fraction, and whatever we think that area can tolerate and whatever the patient can take. And then we do it in a stronger way so that we can really try to wipe this one tumor out with more, and to be more aggressive about it. And so the reason we don't do it on everybody in every situation is because the larger area you treat, the more normal organs around that area, and the more volume of normal organs nearby, we have to be more and more careful because we don't want to cause problems either with radiation therapy. So really any treatment like that has its side effects, and we can ablate anything. But it's a matter of, we also want to make sure patients stay safe with it as well, and that we do this in as safe a way as possible. So that's why we have to find that balance of when to use SBRT and when to use more conventionally fractionated IMRT, meaning that we spread it out a little bit more often in lower doses each time. And of course, even simpler technology is called 3D conformal radiation therapy as well, which we often use because it's faster to plan, it's faster to treat. So those situations where we have a low dose, it may not need to be quite as conformal and be able to treat a larger area, but we can use a simpler technique in that case to get patients started sooner.
It's super interesting. I'm going to share a little bit about my own case where when I first was diagnosed as metastatic, the imaging suggested that maybe I only had a couple spots in my spine. That ended up not being the case, and they did another type of imaging test, and then they saw a lot more spread. So this ended up not being something that I could take advantage of. But originally, when we only thought there were 2 spots in my spine, I started to do some research and find out about oligometastatic disease. And what I learned was that there is some research to suggest that perhaps you could even treat those oligometastatic metastases, especially if they're in bone, with SABR technology that we were just talking about, SBRT, and do it with a curative intent. Now, I know that's controversial. I'd love your opinion on it. What do you think about SABR for curative intent, and who might be eligible for that?
There's a lot there that's controversial, as you said, about it is a very interesting area of research, because I think we all know at this point among physicians who treat cancers that not all stage 4 is built the same. Right? You'll have some stage 4 cancers that are very widespread, and you can see it on the imaging, or sometimes it takes advanced imaging to see it. Other people really only have 1 or 2 or 3 spots that may have extended outside the region of where the tumor started. So when you think about staging 1 through 4, 1 usually means that it's isolated to that organ itself. Stages 2 and 3, either it's a bigger tumor or it's starting spreading to lymph nodes that are in the region that they're expected to go to first before they start metastasizing to other organs in the body. Now, it used to be that when all stage 4s were treated the same way, which is that you would have stage 4 disease, you would find some spread of any sort, and it didn't matter. You just got chemotherapy and that was it. Because and it was meant for palliation. It was meant to try to extend your life if possible, maybe make your life feel a little bit better. But ultimately, the idea was you were going to die of your cancer. Now, that's not necessarily true anymore. And we definitely know now that there are some patients with stage 4 disease where if we treat them aggressively with systemic therapy first, typically, because we want to make sure that at least they're on a drug that is working well for them overall, but that we can also use local therapy like surgery or radiation therapy, or sometimes both, in order to be very aggressive here and try to treat everything that you can see. Now, it used to be heresy to say that, because what people used to say was that, okay, great, you can treat everything you see, but there's tons of stuff you can't see. And there's a lot of microscopic disease that you can only see under a microscope that we just don't know about based on imaging. Now, imaging has gotten a lot better, so we are able to detect a lot better which patients really might be able to get away with really only 1 or 2 spots, that if we treat it aggressively and then treat all the disease, that maybe we will have a chance of very long-term survival and dare I say cure, right? Mm-hmm. I think cure is a tough word for oncologists in general, right? Because it's hard to know when you've cured someone until they have essentially died of something else before the disease came back. That's really the only way to know you've truly cured them. Right. So I think, you can go 5 years, 10 years, 20 years. Is that a cure? It's hard to say for sure. But, with curative intent is the idea that we are aiming for that the goal is to have you live the rest of your days without a cancer recurrence, or at least that cancer becomes a chronic disease that you live with, but that the cancer itself is not what leads to your death or the driver of your death. So that is our goal as oncologists in a lot of ways for many of our stage 4 patients, to say, okay, you have other medical conditions going on too. You have a whole life to live as well. We want to make this such that we can wipe out as much of this as we can and hopefully keep it from coming back, and maintain your quality of life. But at the same time, could we cure you? I think that's still an open question, because we now have patients with metastatic disease, and especially oligometastatic disease, who've made it 10 or 15 years now that we've had this paradigm and we've been using this technology like SBRT or SABR to be able to treat people very aggressively in the right circumstance. We do see these 10 and 15-year survivors now, maybe even 20 years in some cases. And of course, there's a lot of biology that goes into it in terms of the disease itself. Certain cancers are probably more likely to be oligometastatic. Breast cancer is one, for example, that is under question about whether oligometastatic really exists, because there may be a lot more disease out there that we don't know about. And some of the clinical trials in breast cancer specifically have not always shown as much promise as some other disease sites like non-small cell lung cancer in that frame. Now, of course, with breast cancer, we have such good systemic therapies that part of the reason that we aren't always showing a survival benefit to radiation is because the systemic therapies are getting so much better, and people are living long even with just systemic therapy alone. But once in a while, if you have the right patient in the right situation where only one thing is escaping that drug and that drug is working really well, that's called oligoprogressive. Oligo really means few, right? And we have different ways of saying oligo. You could say oligometastatic, meaning you only started with a few metastatic sites. Oligoprogressive could have started as oligometastatic with only a few sites, but only one or two maybe have escaped the systemic therapy you're on, and then you're able to treat that aggressively. You might get oligo recurrence, which means that you're actually not on therapy and you've been fine for a while, but then only one or two things pop back. And that could be in the setting of having had 10 spots or 20 spots up front. But if everything's under control and only one or two have become resistant to either the treatment that you're on or have just come back on their own without everything else coming back, those are circumstances where we really think very closely about using local therapy and trying to address those and continuing on with your life that way with whatever drug you're tolerating well and that's otherwise working. And we often are able to keep people on those therapies for a very long time without having to switch to something that might be either more toxic for them or that may not work as well for other areas in their body.
It's interesting. There's another saber machine called the cyber knife. And I did like the name of that because it started to me to think, okay, this type of radiation, of stereotactic radiation, is like kind of the equivalent to cutting it out as surgery. I think a lot of patients confuse surgery and radiation and its ablative effects. You were talking earlier about IMRT and how it's done and how sometimes you need to be gentler and let the body kind of grow back and keep its health so that you don't damage other organs and create problems. Can you help me just understand just how ablative SBRT is it truly like cutting out the cancer? And is the other type of radiation, like, does it get rid of 90%, 99%? How much does it kill the cancer cells in that area? I don't believe it kills all of them, but do we have a sense for what kind of residual cancer it leaves behind?
Well, it actually could kill all of them in some cases. So, for example, in head and neck cancer, we have 98% survival in some types of oropharynx cancers, maybe some throat cancers, that we're able to cure with chemotherapy combined with fractionated radiation therapy alone with IMRT. So there's many types of diseases, cervical cancer, stage 3 lung cancer. There's many types that we are actually have been able to cure for many, many years that way. Now, not 100%, right, in terms of not all patients are going to be cured from it, but many are. And that often still is a standard of care for many disease sites where you have a lot of lymph node spread already, mostly the stage 2 and stage 3 kind of patients where you have lymph node spread, but it hasn't gone, beyond that area. So I don't want to walk away thinking that the conventionally fractionated radiation is always just palliative. We really are treating with curative intent for many kinds of cancers. Now, with stage 4 disease, that's where it's trickier, right? And that's where, we can usually, think that right now we still aren't saying that stage 4 cancers are always curable, but with that intent of, we often approach it with the intent of saying, why not try, right?
Yeah.
It happens because I think we are seeing these long-term survivors. I'm sorry, I'm not sure if I'm kind of going back to the old question.
No, that's perfect. The other half of it was just, is saber technology truly like using a knife to cut out?
Yes. So the knife factor is not an accident. The fact that the cyber knife is called that way and the gamma knife is called that way. The history of that a little bit, I'll go through a little bit, is very interesting. The gamma knife was really the first time when we used ablative type radiation, and that was specifically for the brain, for not only brain metastases, but even for other conditions that would call that weren't cancer related, that were not cancer related, but that actually were involving pain from nerves and things like that, where you want to ablate those nerves. And instead of opening a patient's head up and doing neurosurgery, some neurosurgeons in Sweden figured out that they can use very high doses of radiation, focus it on a very small area, and see if that works just the same as surgery would. And radiation oncologists thought this was crazy because we always would just do conventional fractionation. And there's a lot of reasons from radiobiology of why that makes sense to do it that way. But the neurosurgeon said, let's just do it. diluted doses as if we're cutting it out. And they were very successful at doing this in their specific circumstances of what they needed to do. So what ended up happening was that over time, people started thinking, is there something we could do outside the brain for this? So that's where, lung tumors, for example, were a really good example of somewhere where you have a stage 1 lung cancer. You're doing surgery and taking out a whole lobe of a lung can be a really big deal and leave you with much less lung function to be able to function and live your normal life and be able to walk around and play with your grandkids and things like that. So the idea was, can we apply this to the lung? The same idea that we did in the brain to the lung. Now, the one problem with that is that lungs move. And every time you take a breath, your tumor inside your lung is always going to be moving. So it really took a while for that to happen because in the brain, everything is very steady. If you put a large frame on someone's head and you screw it into their head to make sure they don't move, which is what a neurosurgeon would do with the gamma knife, you can be very precise about this and know exactly where you're treating, and it will be where you think it is. Whereas in lung, you have to really be sure you had the proper imaging to know, are you treating what you think you're treating? So eventually we had imaging that was capable enough to do this, where we had CT scans. We had 4D CT scans that actually can see, as you took a breath in and out, exactly where the tumor was moving, and be able to draw all the areas where the tumor ever goes, and then be able to, with the idea that even there's going to be some normal lung in there in the high dose area, that you're going to be able to at least capture where it goes and still avoid as much as possible the other areas around it, because of the technology that we had with radiosurgery to be able to have those fall off very quickly from your target to the normal area, just even millimeters away. So that's the kind of idea of surgery as well. When they use a scalpel and take out a tumor, they're not just taking out the tumor, but they are taking out some normal areas near it as well. If in, let's say, a lung cancer, you take out a whole lobe of the lung, at least that was the standard of care for most stage 1 lung tumors. So, you are going to take some normal tissue too, but you are removing it. And that's the idea with this very high dose radiation, like radiosurgery. Again, not an accident that it's called radiosurgery, because it's similar concept, or at least a similar intent, is to really destroy the tumor and not just keep it dormant or keep it down. Even though conventionally fractionated radiation can completely kill tumors as well, it wasn't as successful at doing that. When we applied that into stage 1 lung cancers, we got still a lot of occurrences, more than surgery did. So that's why we knew that for patients who couldn't get surgery, we wanted to do better as a field, and that's how SBRT really started. Was probably mostly in the lung. Was one of the kind of earliest common indications or reasons why we would do radiosurgery. And once you figure that out, then you could do it almost anywhere else in the body. Now, you could treat the pancreas that way. You could treat, the prostate that way. Really, many organs now are now, it makes sense if you have a small area that you can focus on that's not too close to an organ that can't tolerate that kind of dose, then you can go and do it now. And that's why there's a whole field within SBRT or SABR where we're really trying to expand where we can do this, and including bone metastases, for example. Those are some of the easier ones, in fact, because you can see them. Most of them don't move very much. You are able to immobilize them pretty well and keep the patient in the same place. We can treat those, and the bone itself can tolerate it. The bone nearby without fracturing most of the time. But we have to be careful with certain organs, such as the spinal cord or the main airways of that you use to breathe, or the esophagus, because these tubular structures, like, to think of it like plumbing, for example. If you have a pipe, let's say, and you end up hurting some part of the pipe, to a small degree. Let's say you actually have some damage to the whole pipe, but just a small amount. The pipe will still work, right? But if you poke a hole through one part of the pipe, then you're going to get a leak, right? So that's the idea here, is that we want to make sure that even if it's a small area of a normal organ, that we know how much that can tolerate without, causing a perforation or causing a leakage there, because that can be really detrimental to, in terms of side effect. So we've figured a lot of this out now in terms of what doses, what that organ can tolerate in one session or 3 sessions or 5 sessions, et cetera. So that's what's safe to do.
So one of the things you were just talking about was the area around the tumor that you look at when you are setting up SABR technology to treat that tumor. And I'm wondering if you can just talk a little bit about the difference between the current stereotactic radiation machines and the RefleXion machine that you have, because if I understand it correctly, the new machine that RefleXion has put out with the Scintix technology is able to track the tumor a little bit better because of its layering that PET scan right into the radiation technology. So you don't have to have as big of an area that you're treating because, it's tracking to the tumor instead of making a bigger box around the tumor. You can actually track the tumor. Is that correct?
I think so. I think that I think that's a good way of putting it, which is that there's a smaller amount of normal tissue that should get exposed to the high dose part of it. Not necessarily the low dose part. That's a little bit of a different concept. But at least the dose that you prescribe, you're able to not have to put as big of a margin on. Usually what we do with standard SBRT is we say, we have to put a little extra room for the motion itself because we track in all 10 phases of an inspiration and an expiration. So as you breathe in and out, we break that up into 10 phases, and you can see with every single breath, that we can see exactly where that tumor moves. And you basically draw all of those and you combine them in terms of where the tumor is. So it ends up being bigger than, in most cases, especially in the lung, ends up being bigger than if you just took one phase of that and just targeted that. That's what we could do with the Scintix technology is we could just contour one phase or draw out one phase of it alone. And then for each of them, we put a little extra, maybe 5 millimeters of margin on, a very small amount, just to account for the fact that there's always some little bit of room for error that you want to build in, just to be perfectly safe and not miss the target. So no matter what, we're adding that extra margin. But the other step of having to account for all the respiratory motion, we don't have to do anymore because it will just automatically track how it moves as you breathe. And if you take a bigger breath one day because you just felt like doing that, or for whatever reason, or you sneezed, or you coughed, or you moved a little bit, that's a nice thing is that it would track it automatically instead of having to model that ahead of time, because sometimes you can't model everything.
Right.
We what's called a simulation beforehand, so that we can model the way that you normally breathe. And we hope that you do the same thing on the treatment day, but on the treatment day, there's no way to know that it actually is exactly doing what we thought it was going to, whereas the tumor is going to move exactly the way we thought it was going to move originally. So this accounts for that. Now, on a CyberKnife, you can also do that too, but you do have to place what's called a fiducial or an actual physical marker in the tumor in order to do that. But that can track that marker, but not necessarily the tumor itself. But if the marker is in the tumor, it functions similarly, but it's not automatic. And that's why I think that's where this, especially as with the eventual goal that we'll treat multiple tumors eventually, putting markers in every single tumor is going to be pretty tough to do. So, doing this automatically is that this will expand the ability of us to treat more and more patients this way, even if we're not quite there yet.
Yeah, and I would imagine there's some places where you just can't get a marker in.
It's risky to put markers in always, right? If it's in the lung, you got to put a needle in order to go, and it goes through the lung, and it might puncture a lung. So there's there's always some risk of putting markers in also, which is not the most straightforward things. The more automatic you can make it, as is for many things in life, right? More automatic and leave less room for human error, the more possibilities you have of, first of all, not having an error be made, but also for expanding the possibilities of what you can do.
Right. Well, it's funny, and you talk about expanding the possibilities. One of the reasons why, so I've been following the RefleXion company for 4.5 years, ever since I was first diagnosed, and I thought I was oligometastatic, and I was looking at radiation options, which led me to their company. And they had a vision statement on their website that I really wanted to hear, which was, it's changed slightly over the years, but it's basically the same. And it says to reveal cancer as never before and beat it for everyone, everywhere, which is a pretty big vision, But I know that what they were saying before, and I think they're continuing with, is the idea that almost like whack-a-mole, that when cancer comes up, that you someday might be able to control it with Saber technology, where you are treating new places as they come up before they can really cause big problems. Can you explain how much radiation can a body take? I know this is kind of pseudo-realistic, right? I mean, this is a vision, so it's not reality today. If it was, it wouldn't be a vision statement. So this is someday in the future talk. But can you talk about today? How much radiation can a body take? And is this vision something that, who knows, someday? How do you think about it?
I like to think big, right? I mean, I think it's important. I think you have to be careful with not thinking too big for each individual patient, because you don't want to hurt someone, by being too unrealistic, of course. When you have a patient in front of you, you want to be sure you're balanced about that. But as a field, I think we should think big about what we can do for really to really transform the way we deliver cancer care. And if you look at the last 50 years, and even the last 10 years, how much has changed in that time frame. It wasn't always incremental. A lot of it was, very transformative. So I think the vision is great. And I'm very happy about it, even though I know we're kind of far from that point right now. But I think the idea of being able to, how much radiation can the body take at this time? There's a clinical trial right now in Canada where they're trying to treat up to 50 spots.
Wow,
Right?
50, 50.
Yeah, 50 in the body, right? And they're, using a lower dose for each one than we would if we just had one, for example, right? But I think there's more of a proof of concept that if you're very focused with radiation, the cumulative amount in your whole body is not as relevant, because let's say you get a CAT scan. Yes, your whole body or the whole region that was scanned will get some extremely low dose, but that will go to the entire body. If you can plan, radiation to multiple spots. I mean, right now already in the current day and age, I've treated patients up to 6 to 8 times, I'd say, overall in different parts of their body. I'm sure others have done even more than that, and perhaps I have as well. I think it's something where, you might be a little more cautious to do that in a 20-year-old than you would in a 60-year-old or an 80-year-old, of course, because radiation does have potential long-term risks as well. Any radiation exposure, even a very low dose, especially when you're very young, can lead to, higher risk of what's called secondary malignancy, meaning that another cancer can form at some point down the road. But usually that's many years away. And often we're at the point where we want to be dealing with the present now and being able to, your best shot at curing cancer is often, or at least treating cancer is often your first shot. So you really do want to be as aggressive as is reasonably possible, for patients who are able to withstand it. So it's a very fine discussion to have, a very subtle discussion to have with your personal physician and your personal oncology team, your personal oncology team, to be sure that, they understand you and how much you can take and how much you want to take as well, in terms of potential side effects and for what potential benefits as well. So it's really definitely not a one size fits all issue, but it is something where we don't really put a cap on lifetime exposure or number of treatments you've received, because it's very dependent on the details. We definitely need to see, if I'm going to treat someone who's gotten treatment before, I would definitely want to know, to have the radiation plan in my system. And as radiation, if the radiation centers are good, usually about sharing the documentation that we have so that other centers can treat if needed, and know how to account for the prior dose as well. But, we have a bunch of calculations that we do to make sure that that each individual organ is safe and is treated to a reasonably safe, dose. And especially there's some recovery over time as well. So if something was treated 30 years ago and versus just 1 year ago, there may be a certain level of recovery that the organ has made over time as well.
I just want to go back to one point you made, and it's a little bit of a sidebar, but it's so close to my heart. I don't think the cancer patients understand that the first treatment is your most important treatment, that the first treatment, your initial decisions about how you're going to move forward with care, are super important. And my understanding is that it is because cancer gets smarter and more mutated and more complex the more times it comes back. So your best shot of really getting that cancer, killing that cancer dead, as much as possible, your potential curative effect of what you're doing is you're packing your biggest punch right out of the starting gate. Is that true? Can you elaborate on that?
Generally true, at least in the first course of treatment, meaning you don't want the tumor to recur if you don't have to, right? So, it doesn't mean that you give your heavy hitters right up front. Let's say, you have a stage 3 lung cancer. You might say, should we do some chemo and immune therapy first and then surgery versus surgery first and then chemo and immune therapy, for example. I think there's some controversy about that still, but more people are leaning now towards saying, let's save the surgery, let's give you a chemo and immune therapy because we want to make sure that we are dealing with any microscopic disease first that we have, and then we can go to the surgery once it seems like things are overall in good shape, and it may make the surgery work even better at that point. So I just want to differentiate that point from because that's still all one course of treatment, right? So. Yeah. That you're giving the chemo and immunotherapy and surgery all at the same, the order within that, it doesn't matter as much as being sure that you are as aggressive as you can up front within the bounds of what you can take.
Right? That makes sense.
Get it cured and have it not come back, just like you said, that's your best shot. If you didn't do everything up front and then it did come back later, it may come back mutated. It may be more difficult to treat at that point. So, of course, no one wants to have a cancer recur. But and maybe you don't make a decision to go with an ultra aggressive toxic therapy for a 1 or 2% increase in the chance of not having a recurrence. That balance is very individual for each person. But in general, I think it's the right concept, which is that if you think you can do a treatment and it's being offered to you that has a higher chance of this not coming back, then generally that's the approach we like to take because no one wants to see a recurrence.
Yeah, of course. Nobody wants to see a recurrence. You did some research recently that found that the order or the timing of using radiation with chemotherapy does matter to outcomes. Can you talk about what you discovered in that research?
Sure. I think it depends. We've done this kind of work in a few different disease areas, but I think one, my specialties are mostly lung cancer and head and neck cancer. And I think in those two fields, we've known for a little while now that doing things, the chemotherapy and the radiation therapy at the same time is better than doing one than the other. Now, there's a little bit more side effects, of course, as well, but there's also a benefit to cure rates when you do it that way. So patients who can do both this at the same time, we try to whenever we can. So for stage 3 lung cancers, like what's we call locally advanced, meaning it goes to the lymph nodes, and same with head and neck cancer, we tend to use that as a standard of care. Now with immune therapy, that's an interesting question because, people used to want to try that first, doing that after chemo and radiation. You finish the chemo and radiation first, then you do the immune therapy. And that worked better than chemo and radiation by itself with both locally advanced non-small cell lung cancer. And now they found out with small cell lung cancer as well. So then you would think the next thing that makes sense is just to do it all at the same time. Let's see what happens if you add chemo, radiation, and immune therapy at the same time. And actually, so far, most clinical trials and most disease sites have now shown that is not an effective strategy. It's not just necessarily more toxic, which it might be as well, but also just doesn't work. And there may be other reasons for that we're still exploring why. And then there's the idea, okay, well, how about you move it to immunotherapy earlier? Or you do chemo and immunotherapy, and then your local therapy, whether it's surgery or radiation. And there's definitely a lot of interest in doing that, and actually a lot of clinical trials that have shown a benefit in locally advanced non-small cell lung cancer, where you have the tumor that can be taken out, and doing chemo and immune therapy first rather than chemo first, and then doing that followed by surgery is really better. So I think there's a lot of work to be done on sequencing and exactly when to do each therapy. There may be biologic reasons too why some synergize and work better together than they would have individually, and others actually may actually work against each other if you do it in the wrong sequence. And I think there's some concern now that when you give radiation and immunotherapy at the same time, for some certain situations that may actually lessen the effect of radiation. It's somewhat of a paradox. But if you don't time it correctly, that might actually be worse than doing them separately. So I think there's a lot to be learned in that area about what the best sequencing is to use the therapies we know work, just how to combine them properly to get the best outcomes.
Yeah, it's a super interesting area. I believe that radiation and chemotherapy work synergistically, right? They're both associated with donating an oxygen molecule in the tumor microenvironment. Is that true?
Right. So they both damage DNA in similar ways. Immunotherapy is a completely different mechanism of how that works in terms of activating the immune system to fight against cancer cells. And for a long time, actually, we thought and still think to some degree that radiation and immunotherapy may synergize each other as well, and maybe even to help that radiation may actually help with the effectiveness of immunotherapy, not just in the area that was radiated, but also in areas that are not irradiated as well. So that's called the abscopal effect, and something that has been tested a lot and not necessarily shown with flying with flying colors that that's necessarily going to be the case for most patients, but it is a concept that is being explored still that is interesting, because you definitely see circumstances where you give immunotherapy, you radiate one area, and then another area starts responding where it didn't before, even though when it didn't undergo radiation. So there's something there that can be figured out in more detail, but this some of the research that's going on now and what clinical trials are trying to study. And that's why I very much always encourage patients to consider clinical trials, because these are, we can do retrospective research, meaning we can go back and look and see how people did. And that's helpful in a lot of degrees. That's what most of my research has been, is to go look at the data you already have and see, okay, what seemed to potentially work. Mm-hmm. The problem with that data and the interpretation of that data is that there may be reasons why one person got the therapy that they got and someone else got something different that may have nothing to do with the therapy at all, right? So it may just be that one group did better than the other, but it had nothing to do with the therapy and more to do with the selection of the patients who got that therapy. And maybe they were healthier or they were lower risk for some reason. And perhaps that's why we saw a benefit there. But the way to really know for sure that something works is to do a randomized clinical trial, meaning that you actually, that the patient and the physician don't really have a choice about which therapy they get. They, of course, consented to say, we understand that no one really knows which of these two options is better, so that's why we're studying it, and that the patient has to, and the physician both have to feel comfortable with being randomized, meaning being assigned to either one. So if you feel that way and then your physician feels that way too, then clinical trials are great, because then you're told which one you're getting. And then that's the best level of evidence to find out, which therapies actually are the most effective and in which patients. Mm-hmm. When you're on a clinical trial, then you also have a whole level of a layer of support of a whole clinical trial staff that makes sure that the protocols are being followed, things are very standardized, especially these national trials where, if you go to different radiation centers, they may do slightly different things, but here they're really standardizing to saying this is what we consider as a field to be high quality radiation or a high quality, treatment overall. And you're going to be getting that because someone's going to be watching and making sure
right
on the outside to make sure that that's really happening. And many people are going to be watching actually, right, to make sure we have very good, the data is high quality. And study after study, when they've looked at clinical trials, they've looked at those that have followed the protocols more to a T versus those that didn't. Those that followed the protocols, basically did better. Also, facilities that tended to accrue more patients, meaning had more patients be on those trials, often had better outcomes as well.
Yeah.
So there that we always feel like that being on a clinical trial is often the best care you can receive personally. Even there's of course the altruistic reason to try to help the field do better, but even and for future patients 5 years from now to know what the answer is. But even for yourself as a patient enrolling on a clinical trial, there are lots of benefits as well.
Yeah, I absolutely think and encourage people to investigate clinical trials to see if they can find something that might be right for them. It's always interesting to me because academic organizations and hospitals that are offering clinical trials often have a hard time getting enrollment. And yet, as you said, often patients do better when they are engaged in their care and looking for a good clinical trial. And, there certainly aren't any promises, but you would have kind of the most forward thinking, access to the most forward thinking, which to me is a great asset.
I think that's one misconception, is that you are a guinea pig, right? If you're on a clinical trial, that's one of the hesitations I get most, is that you're just experimenting on me. And also the other aspect is people want to control what they're getting. They want to make a decision about what they think is best, right? And I understand both of those points very much so, right? Because the idea of randomization is very scary. Who is deciding this? Why does the computer decide what I'm getting? And the reason is because we have something called equipoise, which means that no one really knows the answer. Your physician or yourself may think you know the answer, but overall, we really don't, right? And that's why we're doing this clinical trial, and that's why it goes through the clinical trials that open are the ones that we really don't know the answer, even when we think we do. So especially when it comes to the randomized trials, it may also be because, yes, you're pretty sure this drug's going to work or this treatment's going to work, and you just have to prove it in order for the FDA to approve it. That is one aspect too, but a lot of times even those what you think is a slam dunk is going to work doesn't always work.
Yeah.
Vice versa, right? So I think we've always learned a lot from it as a field, but also I think each individual patient, just know that you're not being experimented on in that way. It's that you are getting treatments that are deemed to be very reasonable. A lot of times it's just a drug that's already been used for other things, but just being used in a different context or a different sequence. And there's reasoning why that's the case. And a lot of people have gone through this protocol to make sure that this is a safe thing and a reasonable thing to do. So this isn't willy-nilly, just we're going to randomly
absolutely
and just make you go through it. So that's the one aspect. And then the control aspect is true. You don't get the control over it, but sometimes it's better not to, especially when you don't know, than to not have to make that decision yourself. It's sometimes easier too.
Yeah, for sure. There is a research study that you did, I took note of, that demonstrated that even if some tumors are radio resistant, so that would mean that they had been treated with radiation and they persisted, they did not disappear with the radiation, that even though some tumors who were radiation resistant in your body, that there could be other tumors that did respond to radiation. I think that's important to note for patients, because I don't want patients to think that if they had radiation once, that that's no longer an option for them, or it didn't work, because it sounds as though it could work in a different part of your body. Can you talk to that?
That's correct. So there's, of course, the organs themselves and where the tumor is. Sometimes we have to make some compromises depending on how close it is to a certain organ. So if you have a very central lung tumor right next to your airways, we might have to take that to a lower dose than we would if it was really on the periphery of your lung, meaning off to the side and not really close to anything else besides the lung itself. Then we're able to treat that to a different kind of dose. And structured in a different way that might be more effective when we don't have as much to worry about nearby. But also, things, certain areas of the body, just like, some tumors get resistant to the drugs too. They get resistant to immunotherapy or targeted therapy. Others don't. Really, not all of them behave the same way, and there could be mutations in one that are not in others as well. So there's certain biology that we can predict to some degree and say, okay, well, tumors coming from colorectal cancer may behave differently than renal cell carcinoma or melanoma or head and neck cancer or lung cancer. And even within breast cancer, maybe there's certain subtypes that respond better than others. But even within the same disease, one tumor may respond better than the other as well. So it's really, I think there's a lot of work to be done on figuring out how to predict that better. There's a lot of AI being used now in research to try to figure out, is there a way based on the imaging itself or based on the pathology or based on any number of things? Can we figure out who's most likely to benefit from a certain treatment versus someone who might not, and then you don't want to expose those people to treatment that has side effects that wouldn't help them. So I think patient selection is really key, and personalizing therapy is really the goal of oncology in general, right? We do these big clinical trials on big swaths of people because that's really the only way to know in general what works best. But then you want to take the kind of micro perspective as well on each individual patient in front of you. Does this trial apply to you in the same way that applies to the other person next to you, as much maybe or less? So I think these are things that we're trying to do in the next in the current research as well as future research. I think will really be key to figure out how do we give you the best treatment that you can get, not just for everybody.
which is fascinating. And I have to say, there is another study that you were involved with that found that gender actually affected some radiation therapy and who was more likely to respond. I was shocked to see that. Help me understand how gender plays a role.
I
And
think we're still figuring that out of why. The what we've seen now, right? We know that in a lot of cancers, especially in lung cancer and the small cell lung cancer specifically, there's been data suggesting that women have better survivals than men. Now, is it because you're a woman? Is that why? Is it because you have an XX chromosome rather than XY chromosome is why that's the case? Or is it that women have a slightly different disease in some way, or there risk factors that are less aggressive than the men tend to have on average? There's so many reasons and biological mechanisms for why that might be the case. But the thing we're exploring now is I think even more nuanced than that, which is, do they respond to different treatments? Do men and women respond to different treatments differently? So we looked at basically stage 4 small cell lung cancer patients and saw that some people who get that will get chemo alone, and some will also get a little bit of radiation also afterwards. But not everyone does, and there's controversy about that. So some do and some don't. But then we saw, similar to what prior clinical trial also showed, but couldn't really explore too much further. But with more patients, we actually noticed that women tended to respond to the radiation better in terms of their outcomes from adding radiation was higher than men in that particular subset of patients. So I think there's not to say that men wouldn't benefit from it. It's just that women seem to have a larger response for some reason. Again, we can't. That's our next research now. What we're working on right now is figuring out, are there certain genes on some DNA repair genes or proteins that are related to being on the X chromosome or being on the Y chromosome that might matter biologically. We used to think that didn't make any sense at all, but I think there's some work being done showing in certain kinds of lung cancer, maybe there are some differences in those genes between those who are born as men and those who are born as women. So much more to come. I don't want anyone to walk away from this message saying, man, I shouldn't get radiation or I shouldn't get cancer treatment, because it's still very effective. It's just that the sex may be, biological sex may be one factor that may influence things. I really want to distinguish that from a causation, that being a man doesn't make you necessarily more prone to not having good outcomes than a woman. I think really, that aspect, we're not anywhere close to that yet.
Got it. And when we talk about personalized medicine and trying to get down to understanding, who individually N of one would, what would their likelihood of positive outcome from a certain therapy? Are we looking at oncoproteomics? Are you doing analysis of people's tumor to identify mutations? I know that they're doing that from a drug perspective, immunotherapy perspective. Are we doing that for radiation as well?
It's starting to be explored. It's not ready for prime time yet. We haven't really changed too much based on, well, actually, no, we have. I mean, it has to do with drug therapy, of course, but the combination of radiation with drug therapy, I think, is really affecting things as well. So, I think they're all related to a lot of degrees. So it's in lung cancer, for example, we have certain mutations that are just suggest a very biologically different disease process that's going on. And we have certain therapies and certain drugs that may work better for some than others. But we're starting to find that there may be some genes that might be associated with more radioresistance or radiosensitivity, meaning the response to radiation may be tougher or easier to be able to control a tumor that way. So I think really a combination of imaging, of the molecular factors found from the tumor, maybe other factors found from the blood, other clinical factors that are traditional things like age and sex and things like that and stage and things like that. All of those things are valuable in their own way, but putting them all together, that's the challenge right now. And when you have so many variables you can look at, but that's where technology, I think, is there to be able to start doing these really complex analyses and figure out, how do they not only each variable affect things on their own, but how do they interact with each other? Right? That's the factor that I think we haven't really fully grasped yet, but I think we're starting to realize that is probably important too, is the general milieu or the general environment that all these factors are in. There may be interactions that are very complex that we're still just beginning to understand. So I'm very excited about the future of cancer research and of cancer care. And I think with the current technologies we have, I think we have the tools much more to be able to do such complex analysis like this and be able to find out more answers than our traditional studies that we've done in the past that have been limited in terms of the number of variables we could study at one time.
Yeah. Yeah. I'm very encouraged about everything that's coming down the pike. It's super, super exciting what they're able to discern from looking at our tumors and doing genomics work to better understand us on an individual basis. I'd love to have you articulate who your ideal patient meaning the person that you think that you could help, right? Using your new technology at the hospital, you have this reflection machine. Who would be an excellent candidate for that machine so that the listeners could understand and think about, would this be something that might benefit me? Who is that person? Who would benefit from that machine?
Great question, because I get a lot of calls from people all over the country asking about, should I travel to you to get this? And the answer so far has been no to most people, at least not yet to most people. And so I think the main things to know are that you do need to have a PET scan that's fairly recent that shows that it's pretty avid, meaning that it lights up a fair amount on PET scan. There's a number called SUV, or the standardized unit value for PET scanners. And if you see that SUV number, we generally want it to be at least 6. And we also want the tumor to be big enough too, where we're able to really detect it as well. So it has to be usually at least 1.5 centimeters. Those are probably the 2 areas most right now that I ask for when someone calls me, and I ask, to make sure that those would qualify. Now, we also can only do one at a time, right? So I think right now the best thing is if you have only one spot that's either growing despite the treatment that's coming otherwise, or you might have a stage 1 cancer and that's the only spot you've ever had, and that's fine. But generally, we're still at the point where we're only doing one spot at a time. And then what else? I think the other thing is it's only FDA approved currently for lung and bone, meaning it could be from the lung or to the lung. Same with the bone. It could be the tumor arising from the bone or traveling to the bone. Either way, the site of radiation has to be lung or bone right now. We are doing a study right now looking at, and us and the other centers that have this are working on a study right now looking at other disease sites as well, or other locations in the body, such as the GI tract and the liver and the belly and the head and neck region, in the prostate, in the pelvis. So, these are areas that we're exploring now to make sure. We have no reason to think that we couldn't do it there too. But right now, the early studies were all focused on lung and bone, which the ones to, be more likely to move. But, in the abdomen, things move too. When you breathe, things also move in the abdomen as well. So I think there's a lot of reason to think that there may be benefits there as well. But right at this moment, it's got to be in the lung or the bone in order for us to use the Scintix technology. So I'd say for traveling here, I would say you would probably want to come only if you're, if you're, looking for Scintix. Whereas other people are being treated all the time on the machine. Probably 90% of our patients on that machine are being treated with just standard IMRT and SBRT. So, we can do that on this machine as well, which makes it useful because that way, if you don't have a lot of patients who currently are eligible for it, you can still use the machine all day long and to treat other things as well. And there's very good imaging and there's a lot of good things about the technology as well for those too.
Awesome. And so do you have any of the clinical trials using this technology going on at Yale? So is there anybody, are you recruiting? Are you looking for patients?
Really every patient who's getting Scintix, we ask them to enroll on the registry, which is a prospective registry, meaning we collect the data from the treatments and from the patients. We do survey studies to assess quality of life. That's such an important aspect of all of this, is to make sure that we're actually helping people's quality of life and side effects. So, we ask, it's optional, but we do ask everyone if they would enroll on that registry. And then the other, trial that we're currently working on opening is the one I mentioned, which is where we are not treating yet with other disease sites outside of the lung and bone. But if you have a tumor that's not in the lung and bone and you want to participate in this study, even though you won't be getting Scintix yourself, you can undergo basically the whole process so that we can show, that at least the company is able to have enough data to show to the FDA and say, this is feasible. It's possible to do on other organs too, and it's working in terms of the physics of it makes sense, and that we are treating what we think we're treating in those other organs too. That'll really open up this technology to other patients as well with this, just in other organs outside of the lung and the bone.
I recently traveled to see you with a good friend of mine, Mary, and who talked to you about using this technology on a metastasis in her lung. And I just wanted to close with a thought, because if people do travel to you like I did, I wanted to let our listeners know how easy it was. Yale Smilow Medical Center made it so easy for us to get appointments, be seen by the specialists, get in and out of the hospital. And you also talked to Mary about even organizing her treatments, so she came back to get those treatments, that they could be organized to minimize the amount of time that she would have for travel. And I just thought that was just, so amazing to have an organization that was thinking patient first. Patient-centered care was right at the forefront of what you were doing. And I just want to articulate that and see if you had anything to add in terms of the amount of time that someone might spend at your organization if they were a candidate.
Absolutely, and I very much appreciate that. And it was really, really wonderful seeing you here and being able to show you the machines that we have here as well in our whole hospital. So what I think everyone should know is that we do our best to accommodate travel as well. We're used to this. We have people traveling to us for clinical trials for new drugs, and then we have areas where people can stay as well. So we have a lot of patients who travel to come see us, and we want to be as accommodating as possible to minimize the time that they're necessarily spending in Connecticut when they want to go home and spend time with their families as well. So we try to expedite things as much as we can to keep things within a fairly good time frame. So if we do the consultation, we do a lot of pre-work ahead of time to kind of make this your visit as efficient as possible. So we'll get all your records and do as much talking as we can. If we can do telehealth too, I even talk to people by phone sometimes, especially when they're quite far away, just to make sure that if you're coming all the way here, I want to make sure it's worth your time and that you are, you're actually going to be you're eligible for the therapy instead of traveling here and me telling you that.
Yeah.
out. So if it is something that you want to do and that seems like it's possible to do, we'll bring you here for consultation. The mapping scan is called a CT simulation, and then what's called PET modeling. That's the extra step here where we basically do a PET scan on the machine afterwards, and then that also helps us to model the treatment and design it. Now that process after that probably takes a couple of weeks to pull off afterwards. So at that point, we'd probably have you go home, and then sometimes you might be on systemic therapy still. So they may get a dose of that in the meantime back home, and then when you come back, we try to do everything within a week. So if you get 3 to 5 sessions of radiation, even maybe as little as 1, depending on the case, especially for spots in the bone, that we can get away with it, then we'll sometimes do as little as 1 session, and then we can be done just within a few days to a week with all of your treatment. So that's basically the idea. But you mentioned the patient-focused and the patient-centered approach that we take here, and that's very important to us to make sure that we are as flexible as we can be, and really accounting for the patient, not just within radiation and what radiation techniques to get and such, but thinking about your whole cancer care in general and how we fit in with the systemic therapy you're getting, any surgeries you're getting, anything else you need. If you have a brain metastasis that also needs to be dealt with and you need to see a surgeon while you're here, we try to coordinate all that as well. And just thinking about you as a person, right? It's at least important to me, and really I think important to our institution as well, as that we know that cancer is not your whole life, right? It's one that threatens your life, of course, right? And then that can impact your life significantly, but you are much more than that as a patient. And that's a very important core value to me, that I'm not pushing anything on anybody, because I really do think that you have the right to be informed about all your options, the details of them. But then ultimately it's your body, your choice, your life, that you have to make a decision that you feel comfortable with. Even if it's not the choice I would have made, that's okay. I want to give you the alternatives and let you know why I think the way I do, and go through my thought process, but why what you might be thinking also is very reasonable as well, if you have different goals than what I would set for myself or for you. So I think that's just important to know, is that I think most physicians hopefully feel this way, and some may articulate it more than others, but I think most people do feel this way. So let your physicians know who you are and what you care about, because that factors into the choices, because we, as you mentioned earlier, we have a lot of choices in cancer care these days. It's not just a one size fits all. So we can really customize things quite a bit. And that's why, radiation oncology, we're not, some people think it's a technical role where my job is only to figure out how to get radiation in you. I'm a physician who is an oncologist, and I care about the person in the context of the whole, the cancer in the context of the whole person. And that's why I spend time meeting patients. And that's why we all do this, is not just to explain to you what we're going to do, but also to know you and get to know you more about, and that influences not only what we choose for you or what we might recommend to you, but also while we're doing the treatment planning behind the scenes, I'll think about the fact that you really care to avoid this side effect a lot because it affects the way you play with your grandkids, or affects the way you work, or the activities you like to do, and account for that. I don't like to use the word compromise for that, but it's a balance. Really, everything we do is really a balance of what risks we have, and I could push dose more towards lung, or more towards the spine, or more towards the heart, and in certain amounts in different ways. There's a lot behind the scenes that goes on, even if the same, on paper, it looks the same. Lung SBRT, 50 gray and 5 fractions. There's a million ways I can do that. When they take out your gallbladder, or they take out your lung cancer, there's several ways they can approach it. That's why they have to know who you are and what you care about too.
Well, we really appreciated that. It was very apparent when we went to your organization. Yale was exceptional. And I just want to make sure that the listeners know that the care was excellent, and we're very grateful. And I'm very grateful for your time today and for sharing all of your expertise with our listeners. So thank you very, very much, Dr. Park, for coming.
It's really my pleasure. Thank you so much for having me today.
And now, an important announcement. All the information that was provided today was for educational purposes only. I'm a patient, just like you. I am not a licensed or accredited physician, therapist, or clinical researcher. All information provided is not intended as a substitute for the advice of a physician, therapist, nutritionist, or any other qualified healthcare professional.